So we'll read chapter number 97, that is neurocognitive effect. So this chapter we are going to read from the textbook as well as from the other resources. Now this neurocognitive effect of disease as well as treatment, both are encompassed in that, and it is also known as chemobrain. When we discuss of the side effect of therapy on the brain, or better word, cancer related cognition impairment. So cancer related cognition impairment, CRCI. These words are common. First thing, this is a common problem. This runs in continuum. Continuum means it starts from a very subtle problem, like just a small memory problem. So if we want to start, if we start asking patients that any change in memory or any change in naming the object, often we are finding the answer that there is some sluggishness is there. From very subtle to a frank coma, neurocognition is a continuum. Patient can fall anywhere in between. Now, how to check? It is assessment. So this is important. So the most commonly used, this is MMSE. Now MMS, this mini mental state examination. Mini mental state examination is the most common, I will say, screening tool to use. So it's a 30-point based bedside test, 30 point, and it is used to assess the cognitive impairment, delirium, dementia, and this CRCI. So used for these things, we are limiting our discussion to CRCI. Now what it has? So it has component for orientation, which got 10 points. Then registration, 3. Attention and calculation, 5. Recall, 3. Language, 8. And visuospatial, it is 1. So if we look, this all the function is of some higher cognition function. Now it is not difficult to do bedside. So the total point is 30. We can just ask for orientation, what time it is, orientation to time, which year, what time, which season, day or night, the time, place. So this orientation, which country, where you are sitting now, and which city the hospital is there. Then registration, name 3 objects. So ask, name any 3 objects, apple, pen, book. Then after few minutes, tell them to repeat the 3 objects, whether they are at this registration of the thing is there or not. Now attention and calculation. So you can do tables, table of 3, table of 5. So spell backward. So spelling of the thing, like we are seeing CAR, car, then spell it backward, it is RAC. So this spell backward table, these all table of 3, table of 5, table of 7, anything, these all are higher function. Recall, so few minutes back we have given 3 objects, tell them to recall what 3 we were discussing. So then language is naming the object, like pen, watch. You must know that what is the common name of the object. Repetition, without, if, but, how confident is in repetition. Then command. So 3 steps, like take the paper, fold it, put it in the pocket. So if he is following that, then he is following the command, reading and writing. So the language has name the object, repeat it, command, reading, writing. And visual spatial is obviously copy a cube. So you make a cube, 3D photo, and say okay, copy it, or if you make a hexagon, to copy it. So this is mini mental scale state examination, a bedside procedure to know about the cognitive function, used for dementia, used for delirium, used also for CRCI, what we are looking for. So, but the problem with mini mental, if you can see, all of the examination is related to cognition, memory, processing, but the side effect of therapy or the tumor is more than that. So decrease in mini mental score is cognitive decline. What we are getting is cognitive decline can be easily picked up. So we need a baseline and repeat the test to see the difference. So if it is due to chemo brain sometime is the term used. Now coming to what else we have. We have better tools. So tool is MOCA. This Montreal Cognitive Assessment. So Montreal Cognitive Assessment, it is important to know the name. If detail we can understand, it's good. So this MMSE was 30 points. This is also 30 points. And it has slightly broadened the spectrum. So we'll just see. It has visual, spatial, or executive. That from 1 point it has become 5 points. If you look here, MMSE, it's just a visual spatial is having less priority. It has 5 points. Then again the same things are there. Naming, attention, language, and abstraction. So finding out the similarity in the object, delayed, recall, orientation. So minimum requirement of knowing is MOCA exists, that is Montreal Cognitive Assessment is there, again having 30 points, and it is broader than what MMSE was there. So executive function or visual spatial takes 5 score. If we know this, good to know. So like trail making, we'll say okay, take the table of 3 and put alphabet in between, 3A, 6B, 9C, 12D, like this. If he's making the trail, sound for that, 5 marks. Copy the cube, clock, make the clock which reads about 3 p.m., 3:30. So then these are visual spatial. Naming the animal, again 3 marks. Attention, 6 marks. So attention is, he has to follow the command, whether like he has to tap the table whenever we are saying that a bird has been named. So like cow, buffalo, butterfly, crow, he has to tap the table at crow. So he's putting attention. Then there are language, repetition, fluency, abstraction, similarity can be detected, delayed recall, and orientation. So this all the functions, again it takes some 5-10 minutes to calculate these functions. Now mild impairment, what is the benefit of MOCA over MMSE? It detects even milder impairment. So sensitivity is more. It is having more executive functions or visual spatial. So that has got more weightage, and it is not so basic, so it is preferred tool. But the advantage was MMSE was it is bedside of few minutes basic screening. So for MOCA is more suited to our oncology, that is CRCA. Now even this is not extensive because the brain is more extensive. So finally we have neuropsychological testing, that is also known as detailed cognitive assessment. Now detailed cognitive assessment will take 1 to 2 hours, not for everyone. So for doing this, training, or a trained counselor, psychologist, or a person trained in that, it is gold standard. For this CRCI, cancer related, this cognitive impairment, this is gold standard. It has extensive coverage of almost all the domains like attention, memory, executive function, language, processing, speed, and obviously with executive visuospatial. So everything is there, but the problem is it is taking time. So these are it is quite detailed. Psychologists are usually, or counselor trained in that are there. So these are the screening tools. We must know the name, the MMSC that we can do bedside, then MOCA, and this detailed cognitive assessment or neuropsychiatric testing. Now coming back to why this CRCI is happening. So there are few factors which can cause CRCI. One is the tumor itself. So a tumor itself can cause cognitive impairment. Now this has two subsets, that primary brain tumor or METs to brain, and along with the METs we have leptomeningeal disease. So tumor related CRCI is again one common thing. So that's a more logical to think that cognitive impairment means there is tumor. So the primary brain tumor is more often associated with CRCI. We are going to discuss in detail. But let's first complete that what we are going to what is going to cause this. Then treatment. Treatment itself is affecting the brain. What treatment we have? A radiotherapy to the brain. Obviously the radiotherapy is going to cause some damage. So the CRCI there. Then chemotherapy. Chemotherapy which crosses the blood-brain barrier and causes the CRCI. Then we have TKI, and we have immune checkpoint inhibitors, CAR-T, BiTE, everything. So CAR-T and BiTE, this especially as ICANS. We are going to read that. So this treatment related, tumor related. Then there are associated factor. So cognitive decline is not only due to treatment or tumor, but due to distress, depression, anxiety, so sleep deprivation, then cytokines, fatigue, anemia, hormonal imbalance like hypothyroidism, hormonal. All these problems can have cognitive impairment. So the best way to remember is anything which is affecting the patient is actually affecting the cognition also. Then pharmacotherapy, like person having benzodiazepine, opioids, anticonvulsant, steroids for a long. This all is contributing to CRCI. So the pathophysiology of CRCI is having multifactorial thing, and each one can cause CRCI. The CRCI is continuum of disease from subtle change to coma. Now, how CRCI is unfolding? So, if we go deep in pathophysiology, so let's see tumor related. So we have found that 60 to 90% of brain tumor cases have CRCI, cognitive impairment, or impairment of neurocognitive function. Neurocognitive function is going down. Okay, it depends on location, So obviously the left hemisphere is affected. The cognition impairment is more than the right because left is dominant in majority of us. So location and where cortical white matter where it is located, then it can be associated with focal deficit based on location. So, but there is inconsistency with location. So it's not like absolute map. Even a smaller size, even a location away from the cognitive areas, so it can affect. But location is still a major factor. Second is size. A large tumor is likely to cause more decrease in NCF, neurocognitive function. But again, there is inconsistency. Then type of tumor. So aggressive type of tumor is causing more problem with the neurocognitive dysfunction. Like so aggressive IDH wild glioma is having more NCF fall than IDH mutant. So mutant is slightly milder. So this type, size, location of the brain tumor is tumor related factor, but these are inconsistently related. Now coming to mets coming to brain, again factors are same, but there are inconsistency how they are working. So there are anatomical distortion. It seems reasonable to blame for fall in NCF or CRCI. Then there are biochemical alteration in form of pro-inflammatory cytokines which causes CRCI. So scientists have tried evaluated MRI in a normal population who are developing cancer. They found that MRI evidence of CRCI before the onset of cancer was not consistent. So it's not like it can predate. So it was a opinion like if cognition impairment starts, then we can pick up the cancer clue. So it is okay in relapse setting, but not in screening setting. So the relation is complex. In relapse setting, somebody is having a brain tumor treated for it. If the new cognition impairment is there, it can predate the MRI finding, not for the screening purpose. Now, so this anatomical distortion of gray matter, white matter, tract, compression of that, then biochemical, cytokines, oxidative stress, and obviously hormonal change. So we have hippocampus, is hypothalamus, pituitary axis, hypothalamus, pituitary, adrenal, hypothalamus, and pituitary in the brain. Now, based on this anatomy and biochemical, they lead to cell depletion or death in brain areas, and susceptible one is hippocampus. So these all lead to the cognition problem. Now coming to how this art is working. So radiotherapy induced CRCI. Radiation causes acute damage that is usually reversible due to edema, reversible in form of raised ICP feature confusion. Then it causes early delayed damage, that is 1 to 6 months, and this is cognition impairment. Then late damage, more than 6 months. So this late damage is due to that anatomical distortion, like tract damage due to radiation and cortical thinning. So decreased cellularity in hippocampus. So this has been found. So now pathophysiology, how radiation is supposed to damage this thing. Radiation causes endothelial injury leading to microvascular events. Microvascular events what? Lateral hyalinization of small vessel, hemorrhage, thrombosis, so hemorrhage or microbleed. This all lead to necrosis, cell loss, and ultimately leading to CRCI. So acute change was reversible, otherwise early, delayed and late changes ultimately lead to thinning of the hippocampus, cortical thinning, tract fibrosis. These things are there. Now with all these, the oligodendrocytes that are responsible for making myelin is going down, while the astrocytes that is responsible for making inflammatory cytokines is going up. So again, there is disbalance of oligodendrocytes and astrocytes, also responsible for RT-induced CRCI. Now, what else this causes CRCI? So one important factor is surgery. So you remove the tumor. Remove tumor. So we got better in some neurocognitive area. Okay, but the worsening also happened. So surgery leads to improvement in some neurocognitive area like language, learning, memory. So the thing is, this is the tumor, we are removing this much, still improvement is there. So this improvement again emphasizes that the problem was not only anatomical, it was due to tumor cytokines which is affecting the nearby brain. So this sustained or short term, both type of effect is there. Now removal of tumor area, again executive function was negative, so the function will fall. So it's not like it is always beneficial. The surgery has itself a fall in executive function, immediate and later on can increase. So the post of NCF decline is common when we are operating the left or dominant side of the brain. So and greater decline is related to poor prognosis. Then chemotherapy. Chemotherapy which crosses blood-brain barrier, it causes fall in neurocognitive function. So we have like methotrexate, cytarabine, ifosfamide, cyclophosphamide. These all things are well known to cause problem. So the problem is not only with the chemo which is crossing, but on other chemotherapy also. So the problem is direct neurotoxicity, like happened with methotrexate, cyclo, anthracyclines, 5-FU, and there are indirect neurotoxicity. Indirect means suppression of neuronal signal, DNA damage, increasing cytokines. These are indirect method. So this pathophysiology is again by endothelial damage, cell death, ultimately fall in the number of live cells in the brain is the final culminating part. So with the chemo we have hormonal therapy. So we know that tamoxifen has decrease in cognition, subtle decrease, but there testosterone is important. So in prostate we are decreasing testosterone, decrease in cognition. So androgens, the cognition is subtle, like processing speed. If somebody is driving the car, he or she is at risk of immediate reaction is not there. Then visuospatial functioning is impaired. So these subtle changes are there. Now the third set of chemotherapy is immune checkpoint inhibitor and CAR-T-BiTE. So these are immunotherapy or immune related therapies. Immune therapies, these causes two type of problem. One is CRS, that is cytokine release syndrome. The other is it breaks blood-brain barrier. So blood-brain barrier disruption and CRS both combined lead to cytokines and these immune cells and immune agents. What chemo we are giving or immunotherapy we are giving, this access to brain. So blood-brain barrier is no more protecting, and the cytokine is already creating a milieu. Now the cytokine surge and the blood-brain barrier breakage, it leads to problem of ICANS. Effector cells associated this neurological symptoms. So ICAN is a separate topic altogether and very important. So effector cell associated neurotoxicity syndrome, neurotoxicity syndrome. So what we know about neurotoxicity, again it is a spectrum. It can vary from early confusion to difficulty in naming, difficulty in word finding. This is most classical. So person failed to find the word what he was saying, and then slowly progress or increase asthenia, then myoclonus and coma. So whole spectrum is there. One can fit anywhere. Now the treatment of ICAN is obviously it is common with the CAR-T and BITE, not with ICI. So treatment is steroid, then interleukin 6 inhibitor, then interleukin 1 inhibitor, anakinra, interleukin 6 is tocilizumab. So and supportive care. ICI per se doesn't cause ICAN, it causes this encephalopathy, meningoencephalopathy. Encephalopathic feature is more with ICI. So CAR-T and BITE, they are causing ICANS. So this is about how the chemotherapy or the systemic agent is causing CRCI. Now coming to what is the way to take care of this, preventing. So we have approach, preventive and treatment. Best is preventive. How we can prevent? Plan surgery with minimum mutilation. Plan chemo with minimum expected CRCI and RT. The only advancement came in RT. Hippocampus avoidance whole brain RT is preferred over whole brain RT. SRS preferred over whole brain RT. Then we have agent memantine, that is we have read in RT related adverse effect chapter that it is an MDA receptor antagonist. So main advancement came in RT when we have SRS or hippocampus avoidance and memantine, that is NMDA receptor antagonist. So that's a preventive part. Plan chemo, plan surgery, plan RT with these things. Then the treatment. So what treatment we have? We have two subsets, a pharmacological treatment approach and non-pharmacological. So there is no successful pharmacological treatment. It is not not so useful. They have tried, but tried what we can try, this psychostimulant, but the success is not there, like modafinil, donepezil. These are not working so well. So pharmacotherapy is not the preferred one. Non-pharmacotherapy is preferred treatment modality. Now in non-pharmacotherapy, what we have? We have this cognitive rehabilitation. We have exercise. Exercise has been found to be directly related to cognitive improvement. Then good sleep, so sleep hygiene, sleep concept, then mindfulness, and CBT, so combined behavioral therapy. So these things and also treat the associated factor. Anemia, hormone hypothyroidism, fatigue, distress, everything should be addressed. So these are the way of preventing and treating decline in neurocognitive dysfunction. So this concludes the chapter of this neurocognitive effects of the brain, or chemobrain, or CRCA.